The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will be discussing nuclear brain imaging, and we will focus on seizure imaging, tumor imaging, brain death imaging, and finally, imaging evaluation of normal pressure hydrocephalus. Please keep in mind that if my voice sounds a little bit different today, it's because I'm recovering from a viral illness. A few quick announcements. First, I want to remind everybody that there is a discount code section at theradiologyreview.com where you can find currently available discounts I've been able to secure for board preparation and other resources that might be of interest to you, so go ahead and check that out. As typical, I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com, and you can follow at RadRevPodcast on Twitter or Instagram, where I'm currently posting on most days radiology educational content in addition to this podcast that may be helpful for some of you to learn and prepare for radiology board exams. Without further ado, let's get into the questions and answers for this episode. First question: what are common Spect imaging agents that cross the blood-brain barrier? When I ask about common Spect imaging agents that cross the blood-brain barrier, I want you to think of various radiopharmaceuticals that can be used for nuclear brain imaging, which typically uses either Spect or PET imaging. And in this case, I want you to think about what agents we have available for Spect imaging of the brain. And there are multiple, and this is not necessarily an all-inclusive list, but at least for board exams, you should definitely be aware that technetium-99m can be tagged to a few different agents in order to perform brain imaging. And the agents that cross the blood-brain barrier that I am asking about are technetium-99m ECD, ECD, and the other one is technetium-99m HMPAO. And these, because they can cross the blood-brain barrier, can be used for evaluation of things like epilepsy, brain death, and potentially dementia imaging. I also want to throw out that iodine-123 ioflupane is also available for evaluation of dopamine transporters in dopamine transporter imaging, which is often simply referred to as a DAT scan. Remember that technetium-99m DTPA can also be used for brain perfusion imaging, but this agent, the technetium-99m DTPA, does not cross the blood-brain barrier like the others I have mentioned. Next question: true or false? A seizure focus will be hot on technetium-99m ECD or HMPAO imaging in the interictal state. The answer here is false. When imaging with these agents in the interictal, meaning between seizure state, uptake is expected to be less than normal brain uptake. However, if you use these agents to image in the ictal or active seizure state, higher uptake than what is normal for brain would be expected. Imaging in the ictal state requires that the radiotracer is injected during or nearly immediately following a seizure to obtain most accurate results, and that often requires that someone is actively monitored in something like a seizure ward that is geared to rapidly inject patients should they seize to allow ictal state imaging. Otherwise, most seizure imaging would be performed in the interictal state. It is important to remember that a seizure focus in the ictal state would be predicted to have higher than normal brain activity, and a seizure focus in the interictal state, meaning imaging not closely in association with the time of seizure, is expected to show the seizure focus would have decreased than normal uptake. Next question. True or false? Kaposi sarcoma typically shows thallium uptake. The answer here is true, and this is a concept I have discussed maybe even a few times on prior episodes, so we're simply going to move on. Next question. True or false? CNS lymphoma typically shows thallium uptake. The answer here is true as well, and let's continue this series of questions with another true or false question. True or false? CNS toxoplasmosis is typically thallium positive. The answer here is false. Remember, thallium uptake requires active human sodium-potassium pumps, as thallium behaves like a potassium analog. Therefore, human-derived tumors will show thallium uptake in most cases, while non-human parasites, such as toxoplasmosis, will not. Next question. True or false? Brain parenchymal necrosis is typically thallium positive. The answer here is false, especially for board exams. Remember, thallium is a viability marker in the myocardium, and the same principle holds true within the brain. Therefore, necrosis would be predicted to not show increased thallium uptake, whereas entities such as CNS lymphoma would be predicted to show thallium uptake. Let's go ahead and move on to the next line of questions. And I want to take a moment here to frame the next questions appropriately. We will now discuss a few key concepts pertinent to nuclear medicine brain death studies for board exam questions. Note that the interpretation of a brain death study in clinical practice is complex and is beyond the scope of our brief review here, and should only be made by trained professionals given the gravity and importance of the clinical situation and imaging interpretation. What I am reviewing here are questions that can commonly show up on board exams, but I do not want you to mistake that what I am presenting is in any way a complete discussion of brain death imaging or what you need to know for clinical practice. Let's start with this question. What radiotracers may be considered for use with a nuclear medicine brain death study? The answers I'm looking for are that technetium-99m ECD, technetium-99m HMPAO, and technetium-99m DTPA can be considered for use with a nuclear medicine brain death study. Less common tracers that have also been used for this purpose include technetium-99m pertechnetate and glucoheptanate. Note that technetium-99m ECD and HMPAO are more widely utilized as they cross the blood-brain barrier into the brain parenchyma, therefore supporting brain perfusion if you see uptake within the brain parenchyma. Next question. True or false? Technetium-99m DTPA can cross the blood-brain barrier. I already gave you the answer to this question earlier, but I want to make sure that you're paying attention. The answer here is false. Technetium-99m DTPA does not cross the blood-brain barrier, and this is a frequently tested concept. Technetium-99m DTPA therefore only shows information regarding presence of tracer within the vessels around the brain, therefore allowing evaluation of whether the vessels around the brain are patent, but not directly showing diffusion of the radiotracer into the brain parenchyma itself. Next question. What are nuclear medicine imaging findings that support a diagnosis of brain death? There are many answers to this question, and I'm going to follow guidance according to the Society of Nuclear Medicine Practice Guideline for Brain Death Scintigraphy, and please refer to the most recent version in case updates have been made. Interpretation of a brain death study includes that the study is technically adequate and diagnostic for interpretation. A positive scan for brain death generally involves absence of demonstrable radionuclide activity within the brain if you are using agents that cross the blood-brain barrier, but this alone is not sufficient for the diagnosis of brain death, and imaging findings must be correlated with all available clinical findings as well as imaging findings on non-nuclear medicine modalities such as CT and MRI or angiography. Nuclear medicine brain death imaging typically includes flow images from the anterior projection as well as delayed images, often with Spect or Spect CT imaging, obtained something like 5 to 10 minutes after the radiotracer injection. On a normal exam, images will show tracer from the level of the carotid arteries to the skull vertex. In brain death, intracranial blood flow should be completely absent. In brain death as well, the hot nose sign may be seen, which results from blood shunting away from the brain with apparent increased uptake in the region of the nose on the frontal view. The classic teaching is that this results from increased flow in the external carotid circulation with subsequent increased perfusion in the nasal region. That is probably the most likely potential explanation that would be tested on a board exam. However, I've also seen some reports that the hot nose sign can result from increased perfusion to the brainstem or spinal cord, and therefore appear as activity over the nose on the frontal view, also because of blood shunting away from the cerebral hemispheres. The hot nose sign is a commonly tested finding on board exam questions about brain death, and it is key to realize that this is the result of shunting of blood away from the cerebral hemispheres, and this finding can be seen but is not alone confirmatory of brain death. One must be careful not to misattribute scalp uptake via the external carotid arteries as brain uptake from the internal carotid arteries. Lack of superior sagittal sinus activity helps confirm lack of brain perfusion, but presence of superior sagittal sinus activity needs to be interpreted with caution, as you can sometimes see low-level sagittal sinus activity that comes from the scalp, even if brain death is present. Other imaging tests that can be considered for evaluation of brain death include cerebral angiography, which evaluates for blood flow beyond the internal carotid arteries, which is considered by some or many to be the gold standard test, but from my experience at least, this is less commonly tested on board exams than the nuclear medicine brain death studies. One more word of caution that my discussion of brain death interpretation here is for board exam prep only to help prepare for commonly tested concepts. Again, the actual clinical performance and interpretation of brain death studies is beyond the scope of what is covered here. Next question. What are classic clinical features of normal pressure hydrocephalus? 3 classic clinical features to remember for radiology board exams include ataxia, urinary incontinence, and mental impairment or dementia. Next question. What is the underlying mechanism of classic normal pressure hydrocephalus? Normal pressure hydrocephalus results from impaired absorption of cerebrospinal fluid due to some sort of subarachnoid space obstruction, for example related to prior subarachnoid hemorrhage, leptomeningitis, or meningeal-based malignancy that now is causing impaired absorption of CSF. Next, what nuclear medicine agent is classically injected into the CSF for evaluation of CSF flow or normal pressure hydrocephalus? The answer I'm looking for is Indium 111 DTPA, and that is injected via lumbar puncture into the subarachnoid space. Note that Indium 111 DTPA has favorable imaging characteristics for evaluation of normal pressure hydrocephalus, including a longer half-life at 67 hours that can allow delayed imaging for several days following injection into the CSF, as well as the inert nature of DTPA, which is not lipid soluble, so activity remains within the CSF without entering the brain parenchyma. There is also lack of metabolism of DTPA, ability of indium DTPA to be absorbed by arachnoid villi, and again, a generally inert nature which makes a chemical meningitis unlikely. Given the intrathecal injection, sterile preparation of the radiopharmaceutical must be assured. Note that this agent can also be used for evaluation of ventriculoperitoneal shunt patency, where one injects the radiotracer into the VP shunt reservoir and then monitors the course of tracer into the peritoneal cavity to confirm patency. Next question. What are classic nuclear medicine findings of normal pressure hydrocephalus? This is a question I always found difficult on board exams, and it is also a fairly frequently tested concept. So let's go ahead and review some of the key findings. On board exams, expect early visualization of radiotracer within lateral ventricles, with an appearance of radiotracer within the lateral ventricles that may appear somewhat blunted or heart-shaped. You would also expect lack of radiotracer migration to the superior aspect of the cerebral convexities, retrograde flow of CSF into the lateral ventricles, and delayed absorption of radiotracer with persistent visualization of tracer within the ventricles beyond something like 24 to 48 hours. A typical normal study following lumbar puncture will show cephalad radiotracer migration, which reaches the basal cisterns within about an hour, the sylvian fissure by about 6 hours, and the cerebral convexities by about 12 hours, with uptake in the superior sagittal sinus by about 24 hours. Uptake that remains at the site of lumbar puncture may be related to inadequate lumbar puncture with injection of radiotracer external to the subarachnoid space, including uptake within the paraspinal muscles or subcutaneous tissues. A classic positive study on a board exam question for normal pressure hydrocephalus would be a case that shows persistent ventricular activity beyond 24 to 48 hours with lack of uptake reaching the cerebral convexities or superior sagittal sinus. Next question. True or false? Brain tumors on FDG PET may show as either areas of focal increased or focal areas of decreased metabolic activity. The answer here is true. Because the brain cortex is so metabolically active and takes up quite a bit of FDG, brain tumors may have either increased, equal, or decreased activity compared to the normal gray matter cortex, and therefore areas of increased and decreased metabolism must be evaluated as potential manifestations of a brain tumor. Additionally, tumors that have a coexisting component of vasogenic edema may present with a larger region of decreased FDG uptake, as uptake within regions of vasogenic edema is often low or absent. And that brings us to the last and final question for this episode. What other PET tracers besides FDG can be used to evaluate for metastatic disease in the brain? There are multiple answers to this question because multiple additional tracers for PET imaging exist that can potentially identify brain tumors beyond FDG PET, with several key studies discussed here. First, fluoroestradiol PET imaging can show uptake with estrogen receptor positive brain metastases, such as with metastatic ER-positive breast cancers. We should also mention PSMA PET, which can evaluate for metastatic prostate cancer and other PSMA-avid brain tumors. Let's return one moment to FES PET imaging because I forgot to mention that FES can sometimes show uptake in meningiomas. So if you see uptake in something that looks like a meningioma, that is something that should remain in the imaging differential. Let's also discuss dotatate and similar somatostatin receptor PET imaging studies, which can evaluate for somatostatin receptor positive brain metastases. And finally, and this is a non-inclusive list, but let's mention fluciclovine PET imaging, which can also identify brain tumors via mechanisms that include increased amino acid transportation. Other new and emerging PET agents are also being studied for evaluation of brain malignancy. I hope this episode was helpful for many of you. Please download the free study guide on this topic available at theradiologyreview.com if that is helpful for you. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.